Good evening, everyone. This is Ben Knoll, Director of Patient-Centered Research, and welcome to today's webinar. This is our monthly webinar presented by the Global Healthy Living Foundation in partnership with the Autoimmune Collaborative Research Group and Arthritis Tower. And so today's topic is understanding psoriatic arthritis, signs, symptoms, and treatments. And we're delighted to be able to welcome our two guest speakers. It's not every month that we get to have co-presenters, so we're thrilled to be joined by these two esteemed doctors today, Doctors Ogdie and Dr. Walsh. Before we introduce them, though, we just wanted to lay a few kind of housekeeping rules for if you're new to the webinars, just to explain how they work. So everyone is on mute except the presenters. And we do this because we record the webinar for people who are unable to join us live. And then that allows us to keep the recording pretty clear and clean, so it's very audible, even in the recorded version. And we invite you to send questions, so we encourage this to be somewhat interactive. So within the GoToWebinar, you can see a little arrow that says questions. So in that box, you can type in questions, and we'll see them as the organizers. And at the end of the presentation, which will last about between 30 and 40 minutes, we'll circle back to those questions and do all of the Q&A at the end. So I'll moderate that to actually ask the question. So you never, as an audience member, you never have to speak, and you'll actually never be audible because you're on mute the whole time. But we really would love to get your questions so we can all learn. The final housekeeping rule is I guess just that we'll try to address all the questions to the best of our ability, and we'll again make this recording available in the next couple of weeks once we clean it up a bit, and it will be available on the Clicky-Trans website. So with that, I'm going to go ahead and introduce our speakers. So we're joined by Dr. Alexis Ogdie, who's a rheumatologist and epidemiologist at the University of Pennsylvania. The mission of her program is to improve outcomes in psoriatic arthritis through patient-centered research, aiming to develop personalized medicine strategies for PsA and identify appropriate outcome measures for PsA and improve the early identification of the disease. She's an expert in the care of patients with this condition, and she's a founder and director of the Penn Psoriatic Arthritis and Spondyloarthritis program. We're also joined by Dr. Jessie Walsh. She's a rheumatologist and researcher dedicated to improving health for people with psoriatic arthritis and other types of spondyloarthritis. As the director of the Utah Spondyloarthritis program and a co-founder of the Psoriatic Arthritis Research Collaboration, she has 12 years of experience in caring for people with psoriatic disease. And her research interests include also improving early disease recognition and treatment for people with psoriatic disease. And she's on faculty at the University of Utah School of Medicine. So we're thrilled to have people from different parts of the country join us. So with that, Drs. Ogdie and Walsh, I'll turn it over to you to go ahead and start. Dr. Walsh, thank you.
Well, thank you, Ben. I appreciate the invitation to share my thoughts on some of the things that I think are important in psoriatic arthritis. And also thank you for inviting me to work with Alexis. She is one of the giants in our field, and it's always fun to collaborate. Our goals today are to briefly talk about what psoriatic arthritis is and who gets psoriatic arthritis. And then I will briefly talk about how psoriatic arthritis fits under the umbrella of a group of diseases called spondyloarthritis. Then I'll spend quite a bit more time talking about what psoriatic arthritis looks like, including various disease features and combinations of features that patients may have. And I'll use some cases of some actual patients to help highlight some of those important features. And then Dr. Ogdie will be talking about some of the other diseases or comorbidities that co-occur with psoriatic arthritis, and then she'll touch on some of the principles of treatment. So what is psoriatic arthritis and who gets it? Well, psoriatic arthritis occurs in roughly a quarter of people who have a psoriasis rash, and it can occur at any point in the disease. Sometimes it occurs right around the time that the psoriasis rash shows up, and sometimes it's many years later. And much less commonly, the psoriatic arthritis can occur, the arthritis symptoms can occur before the rash appears. And even less commonly, some people can get the arthritis symptoms with only a family history of psoriasis without ever having had a psoriasis rash themselves. And by definition, in order to be defined as having psoriatic arthritis, somebody has to have inflammation in the joints or tendons and spine. And I'll talk quite a bit more about that. But first, just to get a better understanding of how psoriatic arthritis fits into the broader spectrum of the spondyloarthritis disease group, just want to show this picture of the other types of spondyloarthritis. And you can see at the top, there's two groups there, ankylosing spondylitis, or AS, and non-radiographic axial spondyloarthritis. And those two types of diseases are predominated by inflammatory disease in the spine. And a lot of these names are pretty tough to remember, and I don't think it's necessarily worth trying to do that right now, but just get a better understanding of how they all fit together. And then reactive arthritis is a form of arthritis that occurs after somebody has a certain type of infection. And then the psoriatic arthritis typically occurs with the rash, the psoriasis rash. And then the enteropathic arthritis in the green there usually occurs with inflammation in the intestine, and that's usually Crohn's or ulcerative colitis. And then we've got this category of undifferentiated spondyloarthritis, and people with this disease have features of spondyloarthritis, but they don't necessarily fit neatly into one of those other categories. So all these patients with, or all the people with spondyloarthritis here have shared features of inflammation in the joints and tendons and or spine, and then have some other involvement in the skin or intestine and or the spine. So to talk a little bit more about some of the main features, I'm going to talk about a couple of patients. And the first one I'll refer to as Mr. X. And he is a 36-year-old man who developed pain in his toes, and it was on his left foot. And over the course of a couple of days, this pain really intensified and became quite swollen, to the extent where he was having difficulty putting on his shoes, and it was hard to walk. He saw his primary provider and was told that it was probably gout. He was given a prescription for a gout medication, and he took that for a couple of weeks, but really didn't improve. So his primary doc referred him to a rheumatologist because of this pain and swelling in his toes. And by the time he got to the time we saw him, he had additional joints that were involved. So he was complaining of pain and swelling in his finger. He also had some pain in his knee, and he reported that his ankle was really bothering him. He was also stiff in the mornings, more so than the rest of the day, and this was occurring for up to 2 hours after he was getting up out of bed. And when we talked to him a little bit more, he told us that he had some skin issues. In particular, he had a rash on his elbow, and he'd had rashes like that off and on for several years and didn't really think too much of them. And he also had some dandruff, and he said this was pretty severe, and the flaking and the itching in his scalp had been occurring since his preteen years. So these pictures show some of the features that he had, and in particular, in his feet, you can see that on the left there, his toes, particularly this one here, was quite a bit more swollen than on the other side. And in fact, it kind of lost the wrinkles there, and it was swollen from the base to the tip. And we refer to that as a sausage digit. And he also has some swelling in these other toes here. And his finger, he had one joint that was swollen and tender and visibly bigger than the other joints. And he was saying it was hard to make a grip and it was sore to touch this joint. And on his elbow, he had this scaly rash. And he said that that didn't bother him very much, but he'd had rashes like that on and off for years. And then he didn't mention his fingernails, but when we looked close up, we saw that they were a little bit abnormal. And they had these little pits or holes that looked like somebody took a little pin and made some indentations in his nails. So I'm going to talk a little bit more about each of these disease features since they represent some of the more important and common manifestations of psoriatic arthritis. And the first one is the inflammatory arthritis that we see in the peripheral joint. So peripheral joints means anywhere outside of the skeleton or the pelvis. And he had this in his finger, and this is another, you can see another couple pictures here, or joints here that are swollen, that one, and even up there. And the inflammation in the joints occurs because of disease or inflammation in the cells that produce the fluid that lubricates the joints. So these are the synovial cells. And when they get inflamed, they produce a whole lot more fluid, and that's what contributes to the swelling and tenderness. The pain it can hurt no matter what people do, but it tends to be quite a bit worse when people are moving their joint and or touching it. And when you touch that joint, it usually feels kind of squishy, kind of like a grape. And sometimes the joint can turn a reddish or purple color. Importantly, the inflammation in the joints can cause damage to the joint. And this is a pretty extreme case, but you can see when you look here that the tip of this finger doesn't look right. And if you kind of glance at some of these other ones, you can see that the inflammation is chewed away at the bone there. And we can see the same thing here and here. And thankfully, not everybody will have this type of damage. And even when people do have damage from psoriatic arthritis, it's generally not this severe. But it is an important part of the disease, and in particular the inflammatory arthritis of the peripheral joints that we are continually thinking about and monitoring for. Excuse me. There we go. So this next disease feature is the sausage digit or dactylitis. And this occurs when the tendon that runs along the finger or toe gets inflamed. And this is another picture, and Mr. X had it in his toe, but this is a picture in the finger. And you can see here that the entire finger swelled up, and this person lost all the wrinkles in her finger. And this looks a little bit different than what we see with the peripheral arthritis because there's swelling and tenderness between the joints as well as around the joints. And oftentimes it can be discolored with a red or purplish color. And one of the interesting things about these sausage digits are that it usually only occurs in one or a few digits at a time. And I've actually never seen a patient who's had all 10 fingers or all 10 toes swollen at the same time. And at some point over the course of a person's psoriatic arthritis, about a quarter to a third of people will get it at some point over the course of their disease. The psoriatic nails are characterized by specific types of deformities in the fingernails or toes. And some of the more common changes to the nails, include separation of the nail from the nail bed. And you can see in this picture, this whitish color area at the end here, it's lifting up away from the nail bed. And oftentimes the nails will get thick, and then people will have these little holes or pits in the nails. And these are, when you see these holes or pits, it's usually psoriatic disease. And the sometimes the nail disease is pretty mild, and it may go unnoticed until you specifically look for it. And in people with psoriatic arthritis, we estimate about 3/4 will get these nail pins or any type of psoriatic nail disease. And people with psoriasis, skin rash without the psoriatic arthritis can also get this nail disease, but it's more common in the people who also have the psoriatic arthritis. So I'm going to introduce a second case, and this is a 25-year-old gentleman who I saw who had chronic back pain. And his past medical history revealed that he had a psoriasis skin rash off and on since age 14. But his real concern at the visit was his back, and it was painful and stiff. And it came on gradually, and he thinks it really started to bother him at about age 20. And it was in his lower back and also in his buttocks. And it was worse in the mornings, and it typically got better when he got out of bed and started moving around, but oftentimes it took 45 minutes or so before that stiffness was as good as it was going to get for the day. The pain often woke him up at night from sleep, particularly in the early mornings at 3 or 4 in the morning. And he had learned that stretching and jogging actually helped with his back and buttock symptoms. So he went to his primary care doctor a handful of times in his early 20s, and he tried some non-steroidal anti-inflammatories, in particular ibuprofen and Aleve, and they both helped, but they weren't enough to control his symptoms. His primary doc gave him a muscle relaxer, thinking that there could be some muscle spasm occurring, but that didn't really help. Also gave him a prescription for physical therapy, and the physical therapy did help, but as soon as he stopped going, his symptoms went right back to where they were in the beginning. So his primary provider referred him to a sports medicine doctor. And at this visit, he actually had developed a new symptom with tenderness in his heel. This was the back of his heel where his Achilles was joining up with the heel bone. And he had also, upon questioning, remembered that he had some soreness in his toe and wrist in the past, and he thought they were a little bit swollen, but this went away on its own. And then he talked about his skin psoriasis rash. And the sports medicine doctor ordered some x-rays of his pelvis and his back, and then referred him to rheumatology. And at that point, it was a little bit more obvious that he had psoriatic arthritis. And so I'm going to talk a little bit more about some of the key symptoms or key manifestations of psoriatic arthritis that this 25-year-old man had. And in particular, it was the pain in his back and buttocks that were bothering him. And this was occurring because he had inflammation in the joints of his spine and of his pelvis. And the joints of the pelvis and the spine are often referred to as the axial joints. And about 25% of people with psoriatic arthritis will get this inflammatory disease in their axial joints. And there are many different names for this concept of axial inflammation in people with psoriasis. And some people will call it axial spondyloarthritis with psoriasis, or sometimes ankylosing spondylitis, psoriatic spondylitis, axial psoriatic arthritis, spondyloarthropathy, seronegative spondyloarthropathy. And I don't think it's necessarily important to remember all these terms, but just want to throw them out there in case you're familiar with any of them. So there are 3 main features that people who get psoriatic arthritis in their back or pelvis have. And these features often occur together, but not all patients will have all 3 of them. And the first one is inflammatory back pain, and I'll describe a little bit more what that is. And then inflammation in the sacroiliac joints that we can see on imaging, such as an X-ray or an MRI, and we call this sacroiliitis, or inflammation of the spine that we can see on the X-ray or MRI, and we call this spondylitis. So starting with the inflammatory back pain. Inflammatory back pain refers to the nature or character of the pain that a person experiences. And this mnemonic here was designed to help remember some of the most important parts of inflammatory back pain. And the I in eye pain stands for insidious or gradual onset, and that occurred in our patient. He developed his back pain over the course of many months. The pain is typically worse at night and tends to get better when people get up and start moving around. It occurs almost always in people in younger age, usually less than age 40 or 45, and oftentimes can be in the teens or 20s. It tends to improve with exercise, and it does not improve with rest. And these numbers here are not necessarily important to memorize, but the bigger numbers tell us that that particular feature has a bigger impact on the likelihood of this patient having the inflammatory disease in their spine. Another way to think about inflammatory back pain is how it differs from other types of back pain or non-inflammatory back pain. Non-inflammatory back pain actually it makes up most of the back pain that people experience from things like muscle strain or degenerative disc disease or spinal stenosis, etc. So people with inflammatory back pain, again, tend to get or have an onset of the pain at a younger age, usually less than 40 or 45 years of age, whereas people with non-inflammatory back pain can get it at any age. By definition, inflammatory back pain is chronic. That means it's lasted at least 3 months. And most types of non-inflammatory back pain are shorter lived and usually resolve within about 6 weeks. There's quite a bit of morning stiffness that occurs with inflammatory back pain. And we usually think of this as lasting at least 30 minutes, but oftentimes people will have morning stiffness for an hour or two. And with non-inflammatory back pain, people can get stiff, but it's often not worse in the mornings than the rest of the day. Or if it is worse, it's only worse for a few minutes while people change position and get adjusted. Improvement with activity or exercise, but not rest, again, is a big feature that we think of with inflammatory back pain. Whereas people with other types of back pain tend to experience worsening of their pain with activity or moving, such as bending, lifting, etc. And oftentimes they feel worse at the end of the day after they've been active. Inflammatory back pain tends to respond better to non-steroidal anti-inflammatories like ibuprofen, diclofenac, naproxen, etc. And non-inflammatory back pain can improve, but much less consistently and to a lesser degree than inflammatory back pain. And inflammatory back pain tends to be localized, meaning it stays in a specific area, whereas the non-inflammatory back pain may move or radiate to other places. In particular, it can shoot down people's legs. So the second major feature of the psoriatic disease in the spine or pelvis is sacroiliitis. And this is inflammation where in the joints, that connect the tailbone here, or the sacrum, to the outside of the pelvis or the ilium. So it's this joint right here. And in this 25-year-old patient, he had sacroiliitis that we could see on this X-ray with all this extra whiteness here, and it looks like somebody took an eraser and kind of smudged the margins of the joint so they're harder to see. And here's an example of normal sacroiliac joints versus comparison. And these aren't always easy to interpret, and so oftentimes when an X-ray is normal, but we're highly suspicious for inflammatory disease in the pelvis, or if it's just difficult to interpret, an MRI can give us more information. The third major feature of the axial disease or the inflammatory disease in the spine or pelvis is the spondylitis. And this literally means inflammation in the spine. And it tends to occur at the corners here of the backbones or the vertebral bodies. And over time, there can be bone growth that starts at the bottom here and will grow down, and then from the top of the next backbone it'll grow up, and that can cause fusion. And this is a picture on X-ray, and this white bone here shouldn't be there. That's the fusion that occurs because of the inflammatory disease in the spine. And the good news is that most people with psoriatic arthritis don't get this spondylitis in their spine. And even the patients who do get it, most of the time they won't have complete fusion, like as is shown here. It can cause some difficulty with range of motion in the spine, but most people it doesn't end up being severely limited in terms of mobility. So this patient also had pain in his heel, and that developed around the time he went into the rheumatology office. And this is something we call enthesitis. And enthesitis is inflammation where tendons or ligaments insert into the bone. And it occurs in about a third of people with psoriatic arthritis at some point in the course of their disease. And there's lots of different places it can occur, but some of the more common places are in the heel, as shown in this picture here. It's the back of the heel or in the bottom of the heel. And it's very tender to apply pressure to or to touch. Most of the time, people with enthesitis are not actually going to have visible swelling as seen in this picture. So in summary of some of these more important features of psoriatic arthritis, the peripheral arthritis, or the inflammation in the joints outside of the spinal pelvis, is probably the most common disease manifestation. And we also can see those sausage digits, or inflammation of the tendons that run along the fingers or toes. And psoriasis rash occurs in most people who have psoriatic arthritis. And then we can see the psoriatic nails and an inflammatory disease in the spine or pelvis. And then the enthesitis, or this inflammation that we just talked about, where the tendons and ligaments meet up with the bone. So I will now turn it over to Dr. Ogdie to talk about some of the other diseases associated with psoriatic arthritis.
Sounds great. Thanks so much, and thanks for your generous introduction, Jessie. Jessie is an amazing clinician and researcher, and I'm very fortunate to work with her often. So,
Thank you.
I will kind of take us through the conditions associated with psoriatic arthritis, and then on to treatment, and then into questions. So, to make me the presenter, do I need to click anything? Or I can just say change slide. Oh, okay.
Let me make you
show my screen. I think I got it.
Oh, got it. Okay, great.
Can you see my screen now?
Yep. That's yours.
Okay, great. Perfect. So first, a few things about, so we've talked a lot about the individual features of psoriatic arthritis in terms of what we see in the joints and kind of in the peripheral aspects. One of the things that we don't think about a lot is, especially as a rheumatologist sitting in the room in front of somebody, what we're thinking about is your joints. But what we have to keep in mind is all the other things that psoriatic arthritis can affect. And so it's also partly our job to communicate this to you as patients, because you can be advocates for yourself to ask about these things if your doctors are kind of busy thinking about all the other pieces. So it's great to have patients as partners in care in this way. So these are some of the associated conditions. So among patients with psoriatic arthritis, up to 10% over the time of their disease can develop eye involvement. This eye involvement is called uveitis and sometimes called iritis. It's a painful red eye where the light is even painful. So you have what we call photophobia. You just don't want to see light. And it's painful, often associated with a headache. And if you look in the eye, it's often red. And there's sometimes that redness is centered around that kind of blue, what's here, the blue part of the eye. So it's kind of on the just around the outside of the eye. In addition, we'll jump to gut inflammation or inflammatory bowel disease. About 10% of patients with psoriatic arthritis over the course of their disease may develop inflammatory bowel disease. The other terms for this are Crohn's disease and ulcerative colitis. This is not irritable bowel syndrome. Irritable bowel syndrome is actually much more common, but common in everyone, not just psoriatic arthritis, and it's not related to psoriatic arthritis. If you look in a colonoscopy, you would actually see inflammation in inflammatory bowel disease. This is really important as a comorbidity because if we need to know this in terms of selecting therapies, because some of our therapies can manage inflammatory bowel disease and uveitis, whereas other ones could potentially make it worse. So it's important to know. Cardiovascular disease is fairly common in psoriatic arthritis, very common in terms of just having high blood pressure and high cholesterol, and that's often associated with having obesity as well. But in cardiovascular disease, what we're worried about is our patients getting myocardial infarctions or heart attacks earlier in their life than they would otherwise if they didn't have psoriatic arthritis. And this is partly related to having higher levels of inflammation. So we see this in other inflammatory diseases like rheumatoid arthritis and even just severe psoriasis. The more inflammation that's kind of circulating in your body, the more likely you are to build up little plaques within the walls of the artery causing a heart attack. So the ways to manage this are to kind of just be aware of your cardiovascular risk factors. So smoking is bad already, but it's worse in a patient with psoriatic arthritis. Being overweight or obese can contribute to cardiovascular disease. High blood pressure, we want to have that managed. Diabetes, we want to screen for diabetes and make sure that it's managed appropriately so we can decrease the risk for a heart attack. In addition to kind of managing those cardiovascular conditions, we just want people to be aware of this risk so that they develop chest pain or shortness of breath. They're kind of going to the emergency room getting care for that. Other things that we see a lot in patients with psoriatic arthritis are depression. So depression occurs in about up to 30% of patients with psoriatic arthritis. And you can understand why. If you have pain all the time, if you're not sleeping well because of your pain, then obviously that can lead to depression. But if we just leave depression alone, first of all, it has a major impact on quality of life. But second of all, people who are depressed are less likely to respond to therapy. So it's really important for us to also help you as a patient address depression. Fatigue. So a lot of my patients tell me about the fatigue and just feeling like they've been unplugged like this person here, or their batteries run out. The word exhausted is used, just feeling like you come home and you have to collapse on the couch. That can be related to psoriatic arthritis itself when the disease is really active, but more often it's actually related to either not sleeping well, which may be related to the pain itself, or just feeling painful, or just having a busy life too. So, but certainly fatigue is an important component, and we have to kind of examine that as well and make sure that we're looking for reasons for fatigue and trying to address them. And finally, obesity. I mentioned it once, but obesity is very common in psoriatic arthritis. On average, psoriatic arthritis patients are significantly more obese than patients with psoriasis, and than patients with ankylosing spondylitis, than patients with RA, and then control patients or patients in the general population. So it's overall a much more obese population. Not only that, obesity is a risk factor for development of the disease, and obesity is generally going on long before the disease starts. So there's probably some overlay in how the fat cells may contribute to psoriatic arthritis inflammation. So addressing obesity is also really important. Patients who lose 5 to 10% of their body weight are 3.6 times more likely to respond to therapy than patients who don't lose weight. So weight loss is an important therapy as well. Just to mention that when we've kind of talked a lot about all the disease features, but people experience psoriatic arthritis in a whole lot of different ways. So one is through, not able to do the usual things you want to do, like using a knife, for example, or walking in the way they want to, being a family member and participating in family in the way they want to. So if you have small kids at home, having psoriatic arthritis makes it difficult to get the lunches ready and to take care of your elderly parents. So these things are important in that you're changing the structure of your life in some way. It also sometimes changes how people participate in social activities. So people will be too tired to go out, or will specifically avoid being social because they don't want people to see them in pain or to see their swollen joints or their skin. So that can contribute to someone's emotional well-being as well. So anxiety and depression can be, as I already mentioned, are common, and then poor sleep is very common because of all of these different things. So when we're thinking about a treatment plan, we should be thinking about all of these, but at the same time, also, it's important to think about therapy as like talk therapy is an important therapy, because if you have this major change to how you're conducting your life, it can be very disruptive and very challenging to manage emotionally. So talking with a therapist can be really helpful in just trying to figure out different strategies or coping with the changes in your life and figuring out how you can get back to doing what you want to do. It's also important to communicate with your physician these concepts, because we need to know what you want to focus on in terms of getting better. So now I've kind of already talked a little bit about goals then. So what are the goals of our care? Goals of care include kind of targeting what you want, but also controlling symptoms and inflammation in general, improving your quality of life and function, and preventing joint damage. Some of our therapies prevent damage and some don't. And we need to know how important that is. Overall, in 2019, the majority of patients with psoriatic arthritis are not going to really go on to have severe joint damage, which is really important, but it's still a consideration. Shared decision-making should always be a part of how we make decisions in terms of therapy, so the patient should contribute and be able to ask questions and make sure you're getting the information you want. And this should also involve other specialists when we're talking about the bad psoriasis and joint disease. We want to be able to manage both, and a dermatologist may be involved in that care, or a gastroenterologist if there's inflammatory bowel disease. And then the primary care provider if there's diabetes, for example. So non-medication management, I've kind of mentioned some of these already. Physical therapy and exercise are incredibly important, and I can't underscore that. Everybody, even with swollen joints, should be able to move, and we want to get people moving so that we can improve joint function. Weight loss, I already talked about. Smoking is bad for everybody, but it may worsen disease activity. So smoking cessation is important for a number of reasons. Education about the disease, social support, and talk therapy I mentioned. So this is the list of available therapies on the market right now. So I have over here the things that we just used for symptoms. Anything you would see with a star is okay for someone with axial disease, meaning the kind of back part that Jesse mentioned already. But if this one open star is just because this has been demonstrated to work, but has not yet been approved for ankylosing spondylitis, which is what we kind of use as our benchmark for whether or not we can include a star there. So there's the traditional oral agents like methotrexate, Areva, which is a cousin of methotrexate, and sulfasalazine. We don't use cyclosporin very often, but because it's an old drug, it's tough to manage, but we can if we need to. Otezla and Xeljanz are new oral therapies on the market since 2014 and 2017. We have 5 TNF inhibitors. So these are the biologics like Humira, Cimzia, Enbrel, Simponi, and Remicade. For all practical purposes, these are basically identical except for their efficacy for psoriasis is slightly different. Orencia is a medication for RA, but also works in psoriatic arthritis. It does not work for the skin. So that's an important consideration, is how much skin you have. Totes and Cosentyx are newer drugs. They're called interleukin-17 inhibitors, and I'll mention those next. They are, again, for all practical purposes, identical. And then Stelara is a drug approved for psoriasis and psoriatic arthritis. It works really well for the skin. So we generally use this in people with really severe skin disease who might have more mild joint disease. Now, one of the most exciting things is all the drugs in development. So these are all things that are being tested for psoriatic arthritis right now. And a couple of these are nearing, so these top 3 are all in the market for psoriasis already, and they're nearing psoriatic arthritis indications. At least some of the trials are already done. And bimekizumab already has a phase 2 study done, and so does filgotinib. So once you go through phase 2, you have to go through phase 3. So these are now all in phase 3, except for brodalumab, which probably won't go to phase 3. So lots of excitement coming up. All right, so this is a very oversimplified drawing in that it's not completely accurate, but it kind of shows you how these different drugs are grouped together. So I mentioned that we have the TNF inhibitors, which are the biologics that we had around for the longest. And these are the Enbrel, I'm trying to move my little thing out of the way here, Enbrel, Humira, Symphony, Remicade, and there's Inflector, which is a biosimilar of Remicade. These are all the same, work in the same area. Then we have the IL-17 inhibitors, so there's a couple there. And we think that IL-17 is a little upstream of TNF, so you're kind of working one closer to where the inflammation is coming from. On the other hand, TNF comes from many places, so this is not completely accurate in that way. Xeljanz kind of works closer to the inflammatory cell. These oral ones, we don't know exactly how they work, but somewhere in the cellular level. And then these are the newer drugs, Tremfya, Ilumya, and Skyrizi, which are for psoriasis, but eventually psoriatic arthritis. They work upstream even further in kind of preventing inflammation. Now, like I said, very oversimplified, but it just shows you that when you're switching classes of drugs, you're kind of targeting different areas. So that's why sometimes when you don't respond to one in a particular class, we may say, okay, let's try a different class. Let's try one of the IL-17 inhibitors if the TNF didn't work. Or let's try a JAK inhibitor or something different. So that just gives you an idea how these kind of bin. Selecting the best medication. How do we do that? There's a lot of different ways, and unfortunately, there's not a lot of great data yet. This is something that Dr. Walsh and I are working on a lot too. So one is we take into consider all of the disease features, the severity of the individual disease features, like the severity of the psoriasis, the severity of the joints, what other conditions you might have, like uveitis and inflammatory bowel disease. I mentioned that not all the drugs work for those. Liver disease is going to steer you away from some drugs. There's a couple drugs that you don't want to take if you have moderate to severe depression, and so on. So we take into consider all those things, as well as the patient preferences, like oral versus injection versus IV, and is what your insurance says you might have to have. Sometimes that it comes down to what the insurance says we're going to do. So we take all this into consideration when we select the medicine. When we select medications, there's a few principles. So one is that early treatment is always better. The earlier we start therapy, the more likely you are to respond to therapy. Sometimes we need more than one medication, and we have to mix and match some of the medicines. And then all of our medicines require monitoring and adjustment. So you can't just get a medicine and go away forever. You have to come back and get blood work for some of them more often than others. But also you have to talk to your physician every time you are going to go for surgery so that we can stop the drug or tell you how to stop the drug or whether it needs to be stopped and when to restart it. You have to tell us about vaccinations, serious illnesses, hospitalizations, ER visits, kind of those major impact things so that we can tell you how to manage your drug. Believe it or not, because these drugs have changed so much in the last 5 to 10 years, many physicians don't know what some of these drugs are. So you have to be educated enough about the drug, and you have to let us help you know when to start or stop the drug as well. So with that, we've talked a little bit about how psoriatic arthritis is a really heterogeneous disease. It affects many different tissues. And I always say that no two psoriatic arthritis patients look the same. There's a lot of differences in how people experience the disease and how we see the disease in an individual. These associated conditions are really important to managing the disease effectively. And so we have to think about the whole person and all of the things that are affecting you in terms of making the best possible treatment algorithm. And some of the treatment algorithms are not therapies. It's really important to think about non-drug interventions as well to make you feel better. And finally, early diagnosis and appropriate treatment are important for preventing long-term damage as well. So with that, I'll open for questions.
Great. Thank you so much, Jesse and Alexis. This has been really interesting. And there's a number of questions that have come in, so I'll just going to fire away. Whoever, I guess, if this was your portion of the talk, if you want to start it, and then maybe the other presenter could fill in, that's probably a way to proceed.
Yeah, if Jesse.
Okay.
Oh, sorry, go ahead.
So,
Sure.
Yeah, so a few questions about, so I'll kind of back up a little bit and talk first about diagnosis and so on. So someone asked, what's the role of ultrasound versus X-ray? Is an ultrasound used very often? What does it add? What does it contribute?
Great question.
So ultrasound. Yeah, great. So ultrasound is becoming more and more important in diagnosing psoriatic arthritis, and it can be used to look for inflammation in the joints and the tendons, particularly the joints in the peripheral skeleton. It's not as good for looking at the spine or the sacroiliac joints. But oftentimes we can see some inflammation that's occurring earlier or even just differently on the ultrasound than what we can see on an X-ray. For example, if there's extra fluid in the joint on an ultrasound, we can see that. On an X-ray, we can't see that extra fluid. All we can see on the X-ray is damage that's done to the bone because of that extra fluid. And that damage usually occurs quite a bit later than the fluid accumulation. And in some patients who have the fluid, they may never get the damage on the X-ray. So in some ways, we think of ultrasound being a little bit better at picking up early disease and sometimes even milder disease than what we can see on an X-ray.
Okay, great. That's helpful. So next question is about some of the symptoms associated with psoriatic arthritis, and these were a few different questions, and I'm kind of combining them here. So someone asked about their tongue, that they feel like that they said their tongue does not look normal. It looks like a geographical map, and it can be painful. Certain foods make it worse. Sometimes it hurts to talk, and so on. So that's the first symptom to ask about, is the sort of mouth or tongue involvement. Another question was about uveitis. Is that typically occurring in both eyes or just one eye or the other? And then finally, someone else said they have psoriatic arthritis, but she has no pain but terrible fatigue, and wondered if that was unusual. So I guess those are the three symptoms: uveitis, the fatigue, and then also the mouth involvement.
I can take that. So geographic tongue is not directly related to psoriatic arthritis. It's somewhat common-ish thing that can stand on its own. Now, on the other hand, there are two drugs that cause thrush on the tongue, which is different, but that's what usually causes the burning. Taltz and Cosentyx can both cause a little bit of thrush. It's not that common. It's less than 10% of people get it, but if you're on one of those drugs, I would talk to your physician about that. There's kind of oral rinses to get rid of that. The uveitis is most often unilateral or one eye, but can be in both eyes in unfortunate circumstances when people have it in both eyes. And sometimes people have it in one eye and then the other. It's not that common to see it in both eyes at the same time. And then fatigue. So if the fact that the psoriatic arthritis is under control, or presumably given that there's no pain, and then there's lots of fatigue, most of the time in that case, the fatigue isn't directly related to the psoriatic arthritis. It's related to something else in terms of not sleeping well, if there's depression or anxiety. There's also kind of like a chronic fatigue syndrome, which is a spectrum of fibromyalgia. One of the things I didn't mention is fibromyalgia, up to 20 to 25%. Well, the rates vary depending on the study, but let's say around 20% of patients with psoriatic arthritis also have fibromyalgia. And there's a huge spectrum with fibromyalgia. And sometimes we're changing that term to central sensitization because of this huge range. People may have just more of a fatigue variant where they have a significant amount of fatigue, no pain. And then there's people that have a lot of pain as well. So it's a huge range. And so that's something to also talk to the rheumatologist about. But if you're having fatigue and you don't have much pain, also consider seeing a sleep medicine doctor, because they can do kind of a full evaluation sometimes.
Okay, great, thanks. So these next questions are about treatment. And I'll start with the one that's about alternative methods. So someone asked, they said, they can't tolerate oral medication, so they've had to try a bunch of alternative methods like Epsom salts, soaking in a bath with Epsom salts, and they also asked if it was a good idea to try acupuncture prior to oral medication. So I guess to kind of group this into a bigger question, what are your thoughts about alternative complementary medicine, and what should people try, and in what order versus the prescribed medications?
Yeah, I'll take that. So there are multiple approaches to managing the psoriatic arthritis and various symptoms, and many of them are quite complementary to what we think of as the traditional medicine approach. In particular, I have handfuls of patients at least who say that acupuncture really helps with the pain management, and warm showers and baths may also be quite helpful. And my belief and experience is that these alternative approaches can really improve upon symptom management, and we do have to think about them in various ways, because we don't have data with a lot of these that help us understand whether or not they may have any impact on some of the damage that psoriatic arthritis does, particularly to the joints. So if somebody with psoriatic arthritis is accruing damage to their joints, I'll often say, well, I think that acupuncture, Epsom salt massage, specific diets may be great to use in combination with other therapies that may have a little bit stronger evidence for preventing damage and long-term consequences.
Okay.
Yeah, I'll just kind of add to that I fully agree. I think it's really important to have a baseline. The only things that we know that actually take down swelling and then improve the likelihood of developing damage are the therapies that I mentioned. But it's important to combination, but you really have to have one of those other therapies because you can't make it go away. And the earlier we treat you with one of those therapies, the better things are likely to be. On the other hand, if you have no swelling, unless you have axial disease, that's a different story. But if you have no swelling in the peripheral joints, maybe you can have a little extra time. But if you have swelling, you should probably be on a therapy first.
So, Alexis, I think on one of the slides you presented, I saw Methotrexate listed there, and there's some questions about Methotrexate, and a question about whether that should result in nail improvement, so the pitting of the nails that you showed. That's one question about a Methotrexate, and then a related question is, does losing a full day from taking Methotrexate, is that a reasonable side effect to expect? I guess your thoughts about that.
Yeah, so Methotrexate can help nails, but over the course of 6 months, and it doesn't help nails as much as any of the biologics, in my experience. So most people if your nails are really bad, would need a biologic therapy, but you can see some improvement in the pitting over the course of 6 months or so. Nails in general take about 6 months because they're just slow growing. Methotrexate, losing a day, I know people, that's typical, not atypical, so that can happen for a lot of people. And then is that okay? That's a whole different story, which is kind of up to the individual patient. So some of my patients say, okay, I'll take it on Friday night and I'm down for Saturday. And then, if they're not trying to run after kids, then that might be okay. But some of my patients that have kids say, no way, I got to be up and going on Saturday and Sunday to run after the kids. So it's kind of individual by patient.
Yeah, and I'll add to that the exciting thing about getting all of these new therapies in the past 10, 15 years, all of these biologics are new, and some of the oral agents are too. We have a lot more options now. So when somebody comes and tells me they're losing a whole day a week, I usually say, well, let's just try something else. Losing a day out of your life is a pretty miserable thing. Not only did you lose the time, but most of the time people are feeling pretty lousy. So when somebody says that to me, we usually kind of really think about all the other alternatives and see if we can come up with something that doesn't cause so much loss in terms of feeling well and or time.
Exactly. Yeah,
So
I agree.
a related question then is this person, she writes, she takes prednisone plus biologic, and she still has to use a topical steroid for her rash. So she's wondering, should she try a different biologic? Like when is it, when do people know that it's time to try something else?
So I'll address this as well. In general, prednisone is a drug that we try not to use except for short periods and when we're in a pinch. And there's lots of reasons for that. In particular, prednisone has the potential to cause quite a few side effects with bone strength and muscle weakness and skin thinning and cataracts and all sorts of reasons that in the long term we try to avoid prednisone. And another one that's specific to psoriatic disease is that when you come off it, the psoriasis rash can actually get worse. And then in terms of having to use the topicals, in an ideal world, we'd say, gosh, it'd be great if we can get one biologic or one drug to take care of everything so you don't need any other drugs. That's not always feasible, and oftentimes people will say, yes, this drug has made my psoriasis a lot better, but I still use topicals here and there to make it better. So I think, without knowing the specifics of the situation, I would say that if you're still requiring prednisone and not just for little tiny short times, then I would consider the disease to be not optimally controlled, and I would be thinking about alternative approaches.
Yeah, and some of those approaches might be adding another oral medication. So instead of the prednisone, so as much as possible, we try to get people off of prednisone. Sometimes it's just too hard to get it all the way off, but we try really hard not to have people on it at all. And we also do try to maximize the biologic someone's on. So if someone's skin is bad, but their joints are really good, sometimes what we do is try to get the dermatologist involved, and maybe they'll do a little light therapy, or it's kind of goes, like Jesse said, it's a case-by-case basis. But there's a lot of things we're thinking about. One is not losing that particular biologic if we know it works for the joints. So we might add something, but it's always tough.
This is a question back a little bit to diagnosis and classification of these different conditions, but there was a question about if when someone gets a diagnosis, do they typically get spondyloarthritis as a general diagnosis? And I guess related to that, what's the difference, or what are the main differences between ankylosing spondylitis and psoriatic arthritis? For example, is it just the psoriasis-related feature that makes something a psoriatic arthritis? I'm sure it's more complicated than that, but I wonder if there's a way, sort of simple way for patients to understand.
That's a great question. So, and to be honest, the names here and the nomenclature surrounding psoriatic arthritis and spondyloarthritis are quite messy. And this partly has to do with the fact that our understanding of the diseases have been changing over time as we've gotten better therapies and gotten better images. So we think of them a little bit different way. And so there are people will use all sorts of different terms to describe the same disease now. And so some of these terms, like non-radiographic and axial spondyloarthritis, that's an awful term. It's a complete mouthful. And that term is probably used more appropriate for people studying the disease than people who have the disease. But it does give us information about the disease characteristics and how those patients or people with those diseases should be monitored and treated. Now, the difference between psoriatic arthritis and ankylosing spondylitis sometimes are absolutely nothing, meaning that a patient can have ankylosing spondylitis and psoriatic arthritis, and that means basically they've got the inflammatory disease in their spine, and they also have psoriasis. And usually, when they've got the psoriasis and the inflammatory disease in the spine, they're going to have manifestations in their other joints. It's fairly uncommon to have psoriasis and the axial disease only, but it can happen. And so some people will say, well, they call it ankylosing spondylitis with a little bit of psoriatic disease because their AS is the predominant feature of their back disease. Whereas other people will say, oh, I've got psoriatic arthritis with some axial disease or some AS because it's a little bit less prominent. And I think there's just about every variation in between because there's so much overlap there and some evolution in terms of the words or the terms that are used to describe these diseases.
Okay, that's helpful to know that it's not. I guess it's kind of reassuring that it's not quite as cut and dried as you know, as in reality. I just think there is a lot of overlap, is what you're saying.
Absolutely.
So with that, I wanted to. We're at the top of the hour, and we've addressed as many of the questions as we could. If there's other questions, we may try to follow up with the two presenters and get them posted when the webinar goes up on the website. But just wanted to conclude by thanking Dr. Walsh and Dr. Ogdie for the time this evening and for this wonderful presentation, very informative and useful. And just a reminder to all of the participants that we've been recording this webinar and we'll make this available at the QC Joints website on the webinars page sometime in the next few weeks.